This is a practice that is deeply rooted in my culture, and it is an orthopedic nightmare in our area. So the slides are mostly going to be in Spanish. I will be speaking in English so that people can understand. So this is the plan of the presentation. We go into the definitions. We'll be telling you what is traditional bone settings and who are traditional bone setters. We'll give small information on the origin, then the training, the role of traditional bone setters in the community, method of treatment. We have a case presentation, then the complication that we see in our hospital as a result of traditional bone settings. Then we'll also give a report of the 1-year data collected on the study that we are doing on traditional bone setting. So the definition, when we talk about traditional bone setter, it refers to the practice of diagnosing and treating musculoskeletal problem using the indigenous knowledge. It is usually non-surgical method. The people who practice this kind of activities are called the traditional bone setters. They usually treat fractures and dislocations, but occasionally they can treat other lesions like tumors as well as infections. The other name for traditional bone setters are the bone doctors, and these are people that are highly respected and protected by their community. So, little bit of the history. It is existed centuries ago. For example, the reduction of bone using manual manipulation was documented in ancient Egypt as early as the 1600 ACE. Also in the ancient Greek, reductions of bone by manual manipulation and the use of the Hippocratic bench was also documented 460 years before Christ. But however, recently, this type of practice is only found in Africa and in Asia and some part of South America. So the training, how do they get training? They don't have any formal training. The knowledge and skill are passed from one generation to another within the family. What it means is somebody become a traditional healer because your grandfather was a traditional bone setter, then it passes to your father, from your father to you. The females can also be a traditional bone setters. The knowledge is usually passed down orally by apprenticeship and by observations. There is no important prerequisite for becoming one. The most important one is to be born into a family of traditional bone setters. The role in the society. In their community, they are responsible for the treatment of musculoskeletal injuries. They also give treatment at a low price. They give psychological and emotional and spiritual support. They are sometimes called the community healers, and they're supposed to preserve the family heritage in their community. What do they treat? Their treatment range from simple things as simple as contusion to the complex thing as tumors. In between, you have the spring injuries, the fractures, dislocation, as well as the infections. When we look at the patient, we have a typical traditional bone clinic. In this clinic, you have the doctor, you have the patient, and around you see the tool that they use. They are usually gathered from the environment, and there you also have the family members who are behind. Usually, their diagnosis is by palpation and by inspection. There is no method of investigation. So the reduction technique changed from culture to culture, but in common, they all want to return the bone to its original position by manipulation, by traction, counter-traction with the help of the family member, by applications of pressure. It happened in certain cases where the doctor will stand at the limb that had a fracture in order to reduce it. Some of them will also use incantation. What it means, they will be reciting certain words, which they believe that will return the fracture to its previous position. So after the reduction, like us, they want to maintain their reduction by giving them a splint. The nature of the splint is usually determined by the environment they find themselves. Like if they live in a country where they have a lot of bamboo trees, so the splint is going to be made from bamboo tree. Also, if they are in a country where they have a lot of animals, most likely the splint is going to be made from leather. Also, if it is a small bone fracture like the fingers, they may use cloth, they may use the leaf of tree as a splint. However, in the Gambia, these are the type of spleen that we have. This is called the bamboo spleen. The bamboo spleen is a ready-made splint. It is already there in the clinic. Once the patient comes, the diagnosis is made, and then reduction is done. This spleen is placed around the affected site, and it is fixed in place by either a rope, a cloth, or some charms that are attached around the fracture site. And this kind of spleen is usually made for smaller bones like the forearm fracture. You hardly see this in the limb like this case. The other spleen that we have is the wooden spleen. The wooden spleen is the most common type of spleen we see in the Gambia. These are made from sticks that they carve from the environment, and they put them in different shapes and sizes in their clinic. Once they have the patient, they do their reduction. This is lined around the fracture site and is attached using a rope, a bandages, or even cloth like we see in this case. And for this kind of spleen are usually made for bigger bones like the fractures of the leg and fractures of the thigh. This is another type, a leather type. This is not commonly seen in the Gambia. And this is another type of bamboo spleen that we see in Gambia. So concussions, these are things they get from plants. They are from the plant leaves, from the roots, from the fruits, from the flowers, from all parts of the plants. They usually convert this into various shapes that are used during massaging, because one of the most important techniques in their reduction is massage. When they are massaging, they apply this on the affected sites, and it is believed that it helps to alleviate the pain, reduction of the inflammation, as well as in the healing processes. However, when they put this in an open wound, it can be a source of contamination and subsequently infection. It can also cause reactions on patients whose these concussions are applied. In our patients, we try to find out their preference of treatment. So when the question was asked to our patient, like if they have musculoskeletal injuries and they have an orthopedic surgeon here, they have a traditional bone setter on the other hand, where do they go? What do they prefer? You'll be surprised to see that 90% of Gambians want to go for traditional bone setters as a choice of treatment. And this is in line with what was found in Nigeria, 85%, in Ethiopia, 95%. In Ghana and Tanzania, on the other hand, are low, 63% and 60% respectively. Elsewhere outside Africa, in India, they reported 60%. So from this information, we can safely say that traditional bone setter is the first choice of treatment for many patients in musculoskeletal problems, especially in Africa and in Asia. So why do they go? When we ask them why do they go for traditional bone setter, this is where the reason they give us. Accessibility. Like even if they live in the most remote part of the continent, they are always close to a traditional bone setter. They also talk about the low price, that the price are low. But if you look at it, the price is not all the time low, but there is flexibility. Like if you go for traditional bone setting, if you don't have money, you can pay giving animals, you can give them land, you can go and work for them. The payment method is very, very flexible. And because of that, patients prefer to go to them. Another reason is also they play with the psychological as well as the emotional aspect of the patient. And because of that, they are very close to their patients. There is confidence and familiarity. They grow with them in the same community. They know each other. So because of that, patients also want to go to them. Other reasons are some of our patients are afraid of surgery. Others do not want to have metal into their bodies. And others, because of amputation, they don't want to come to the hospital. So what is the problem and the challenges? It's because there is no formal education, no standard protocol to follow, and because of that, the infections and complications are so many and they are so severe. Sometimes we lost a patient just because of fracture. Sometimes we lost a patient that do not even have a fractures. And sometimes we have to amputate somebody that didn't have a fracture but went for traditional bone setting and come back with gangrene, and then we have to amputate. So because of this, so here we have a clinical presentation of a patient, 16 years old boy, like any other Gambian. On Saturday, they want to go and play football. The boy went to play football and received a tackle from the opponent, then sustained a closed tibia fracture. This boy was taken to the family, to the traditional bone setters, who reduced and immobilized with the wooden splint attached, the boy was sent home. The boy went home. Instead of getting better, the leg swelled more and the pain got worse. The boy was taken back to the hospital with the sign of sepsis. He came presented with tachycardia of 121, fever of 38.3. Boy was pale, and the signs of diagnosis of wet gangrene was made. Boy was admitted on antibiotic, analgesic, blood transfusion, and consented for amputation, which the family refused, and take the boy back home. The boy later go into sepsis and died. So we have other cases, similar story like the boy. This is a woman, 40 years old, who had small injury in the thumb, went for traditional bone setting. For 2 months, they were applying concussion on the thumb. She ended up having abscess and infections of the flange. So he came to us and she was amputated. This is another boy, 24 years old boy, also Saturday football, sustained open fracture type 1 of Gustula and Anderson, went for traditional bone setting for 4 days, come back with ischemia and then gangrene of the limb. He was also amputated. This is another boy, 25 years old, fall from a roof, maybe a mason fall, then went for traditional bone setting for 3 weeks, came back with dislocation. Another adult, trauma, went for traditional bone setting, came with dislocation. This is another child, 8 years old, also fell down, went for traditional bone setting, came after 2 months with septic arthritis of the hip and dislocation. So we have another 24 years old boy, also trauma, AC joint dislocation, soft tissue infection. These are other patients. The first one is 3 years old baby, fell down, taken to traditional bone setting, come with compartment syndrome. The next one is 11 years old, and then the last one is an adult. We also have other complications like this is malunion after spending years with traditional bone setting. Then we have another malunion, plateau-tibial malunion, non-union, bilateral fracture of the femoral neck, non-union, elbow fracture, distal humerus fracture, fracture dislocation of the ankle, and subtrochanteric fracture. So because of all these things, and these people are highly protected in the society, we decided to collect the data from the hospital. And this is our slogan, no more disability accepted from traditional setting. And we use the child because these are the ones that normally suffer. Because when they have trauma, they are the ones taken to the traditional bone setting. They don't choose to go, but their parents take them there. If we want to amputate them, their parents refuse and take them home. So they die, their parents continue to live. So because of them, we decided to put the child as part of the logo. So, and now we're going to talk about the Bossert study, which is the epidemiology and the results of musculoskeletal treatment with musculoskeletal treatment by traditional bone setter. And this is the objective. The objective is to describe the epidemiology as well as the outcome of patients who consulted the traditional bone setters for musculoskeletal injuries and then come back to Edward Francis Small Teaching Hospital. So the data I'm presenting is 1 year, 1 center prospective data. Data was collected from our data site on the day of the presentation at 3 months, at 6 months, and at 1 year post-op data were collected. The data is usually collected by the data collectors that are employed by the AO Alliance. Data is uploaded to our website, which was exported and analyzed using Microsoft Excel. The criteria of inclusion were patients who have musculoskeletal trauma, went for traditional bone setting and come back to us. Patients who, the criteria of exclusion were patients who decide not to be part of the study. The limitation is a small sample. Declaration, there is nothing to declare and there is no conflict of interest. So in a period of 1 year, we have 125 patients, 77 of them were male, 48 were female. The age range was between 2 years and 96. The average age was 34.5. The durations of symptoms before presentation to the hospital was between 2 days to 12 years. The duration the average duration was about 3 months, and then most of our patients were coming from rural setting. 64% of our patients have monthly income that was less than $200. Causes of trauma. Most of the causes of trauma were road traffic accident. This was closely followed by fall from height. The fracture distribution, lower limb was twice affected compared to upper limb. Concussion use, most of the concussion they used were butter. We have a lot of shea butter in West Africa. They were using shea butter as well as butter from goat, the goat fat from goats. They also used other concussion. They couldn't specify. Vaseline was used in 5%. Concussion of chemical and plant origin were in 12% and 12% each. Material used for immobilization, most of our patients use the wooden splint. Bamboo splint was used in 5%. Others not specified were also significantly used by our patients. Patients that have splint on presentation were about 25 patients, which is 20% of our data. Most of them have already removed their splint before coming to the hospital because they wait for 3 months before coming. Fracture classification, most of the fractures were closed fractures because the traditional bone setter does not want to treat the open fractures, and patients do not want to trust them with the open fracture. It arrives that when they have open fracture, they want to come to the hospital, but they will tell us, doctor, what we want is just close the fracture, secure the wound, and then leave the bone, do not touch the bone. And in that case, what we tell them that we cannot treat halfway, we either treat you or you go. Some of them will either choose to stay with us, and others will go. So we have 18% of our data that had open fracture when they were going for traditional bone setting. So antecedents, most of the patients in our data, they are young, average age 34.5. Only 20% of them has diabetes, high blood pressure, or the combination. So diagnostic, most of the patients had fractures, about 97 had fractures, 1.6 had tumor, and other 1.6 did not have fracture or tumor. So intervention, at 1 year, 80 patients were treated, 28 were waiting for surgeries, 5 were amputated, 3 had died. Then we have 28 that were waiting for surgeries, 1 that was advised and sent home. We have 3 patients that were sent to the outpatient department, and then 4 close reduction under general anesthesia. At follow-up, 94% of our patients were improved and they were happy. 6% said that they remained the same, and there was no patient who got worse. So complications, we have lots of complications because one patient could come with so many complications. We had deformity, mostly from malunion and non-union was the most common complication we saw. We also have skin maceration because of allergic reaction to the concussion put on their body. We had chronic osteomyelitis, septic arthritis, muscle atrophy, pressure sores, septicemia, wet gangrene, dry gangrene, and joint stiffness were all common. So here what we try to do is we try to take the group that have the most severe complication and try to see what was common in them. So we had 5 amputees. If you look at their ages, the youngest is 10 and the oldest is 51 years old. Sex, we have 2 females and 3 males. The region, in Gambia, we have 7 administrative areas. If you look at this patient, they are coming from 2 regions, which may means that the traditional bone setters that are in this region are the worst one. If you look at religion, all but 1 were Muslim. This is representative of our country. 95% of us are Muslims. We have 2 students, we have 1 farmer, 1 housewife, and 1 civil servant. If you look at the time it took them before coming to the hospital, the lowest was 21, that is 3 weeks. The family size was, the monthly income was also at the lower side, but this was not, this was comparable to the rest of the population, and the monthly income was also low. And we did not believe that this contributed to their outcome. So you look at the type of injuries they have. All of them had closed fractures. All of them had, all of them had closed trauma. All had fracture except one who had knee dislocation. If you look at the treatment they received, all of them received similar treatment. If you look at the duration of consultation, the lowest was 3 weeks. Then we had 3 wet gangrene, 1 dry gangrene, and 1 pathological fractures. We did 5 amputations, 2 amputations of upper limb, 1 above elbow and another 1 below elbow. 3 amputations of lower limb, 2 above and 1 below knee. So we look at the people that died. They are older. 51 is the youngest, and then 78 is the oldest. We have 1 female and 2 females. They are coming from URR and West Coast. They are all Muslim. We have 1 housewife, a farmer, and jobless somebody. Then family income and family size, we believe, did not influence their outcome. So you look, this is somebody who had a trauma, was on traditional bone setting for 3 years, doing massage. Later, a mass started coming out from the trauma side. He came to the hospital with diagnosis of advanced trauma and respiratory failure, so he died. The other one was a patient who had insect bite in the hands, a diabetic patient, high blood pressure patient, went for traditional bone setting, was tied for 38 days, come with sepsis, resuscitated, and died 8 days within admission. The last one was a patient who had a fracture, forearm fracture, immobilized for 63 days, that is 2 months, 7 days, come with septicemia, resuscitated, but patient died at the age of 52. So right now, as we speak, we have enrolled 300 patients. Most of them are female, 60%. Most of them are 20 and below, 45%. We had 8 amputations. However, the mortality remained the same. We will be at 3 years of data collections in April. So the way forward is we intend to sensitize our patients, sensitize our caregiver, sensitize the community, and we are planning by mid of this year, we'll be training the traditional bone setter on basic principle of fracture management, the basic principle of sepsis technique, first aid training, as well as compartment syndrome, the danger sign, and to refer patients when it is beyond their capacity. This will improve their capacity and will also foster better collaboration between modern medicine and traditional medicine. Takeaway message: Gambia, like many other countries in Africa, traditional bone setter remains the first choice of treatment for patients with musculoskeletal injuries. The data we presented here is 1 year data collected from our study, which help us to identify as well as document the complications associated with traditional bone setting. This will help us to minimize the outcome in the Gambia, also help us to improve the outcome, train more orthopedic surgeons, as well as to create awareness in our community. So last but not the least, this is Gambia. Gambia is the smallest country in mainland Africa. It's surrounded by Senegal in all the 3 sides except in the Atlantic Ocean. Our capital is called Banjul. This is our hospital, the main gate of the hospital, and this is inside the hospital. It is called Edward Francis Small Hospital. So thank you everybody for